Okay, so assalamu alaikum everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fifth year medical student, and inshallah, today I'll be doing the second part of the renal crash course. This time I'll be covering urology. Now, just like all my sessions, it will be a very interactive, and most of this session actually will just be identification based. So I'll show you a picture, for example, and then you tell me what it is, and I'll give you obviously tips and tricks on every disease, inshallah, in urology. Now, this will cover all of the pathologies from the renal cysts all the way to the tumors lectures. It will cover all of micro. It will cover all of radiology and, inshallah, the last pharma lecture that you had, and some aspects of clinical urology, which is mostly overlapping. So without further ado, let's start. So the way I organize the session, it will be divided based on the organ. So we're going to start with the kidney, then move to the ureter and the bladder, then the prostate, and then the testes. And lastly, I'll cover all of the infections in one go. So to start off with, it's just simple urinary tract anatomy that we learned back in first year, is that we have obviously two kidneys that are located in the posterior abdominal wall, retroperitoneal, and then we'll have the two ureters that drain into the bladder and then the urethra. That's just as simple as that is. So now, when you're diagnosing any kidney diseases, we firstly go off of history and physical, obviously. Then we have some lab investigations, which we mostly dealt with in the nephrology section. Then we have imaging, okay? Now, if I tell you and ask you for majority of the renal diseases, of the kidney diseases, what is the first line modality that you would order? Usually it's ultrasound. Why is that so? Is that it's very safe, easy to use, no radiation, and you can clearly visualize the kidneys. Now, how do you visualize the kidneys on ultrasound? Is that it is hypoechoic to the compared to the liver, okay? And you can clearly tell the kidney here, and this is the medulla of the kidney, okay? Now, this is the first line modality that you'd use for majority of the kidney diseases. Now, let's just say I ask you, is if you have someone presenting with renal stone, what is the gold standard modality here? Gold standard. CT. Good. Is there a role in X-rays? Maybe. However, not everything will show up in X-rays, and I'll show you in the next slides, inshallah. So now we have the actual X-rays. Now the X-rays will show you only one type of stones, okay? We usually don't use X-rays for any diagnosis in urology. It doesn't really show us a lot. It shows us maybe hydronephrosis. It shows us one type of kidney stone, which is what type? The calcium stones. Why? Because they are radio-opaque. Radio-opaque means that they pick up radiation, okay? So anything that is calcified, for example, bone, as you can see in this X-ray, will pick up radiation because of calcium, okay? So radio-opaque stones, such as calcium oxalate stones, you can pick up on X-ray. However, all the other types, for example, uric acid, struvite, and stuff like that, then what's it called? You won't be able to see it majority of the time. They are called radiolucent stones, okay? That's why currently, in the current practice, we don't opt for doing an X-ray, okay? Now, there's another form of X-ray, which is IVP, which is intravenous pyelogram. Now, in this case, we give a dye, okay? So when you're giving a dye, you need to make sure that the patient does not have any underlying kidney disease, okay? That's the most important thing. Because if they do, then obviously they will go through toxicity. So in this case, you can clearly tell the collecting system of the entire kidneys and the urinary tract. Now, if there is an obstruction here, this would cause backflow of fluid, and you can pick it up on IVP. Again, in majority of the cases of stones, tumors, all these diseases, you don't go for X-ray. If it's an answer in the question, you don't pick X-ray, okay? First line, usually ultrasound, because it's very safe and we usually use it on the go. However, the gold standard is this, okay? This is a non-contrast CT, okay? Now, how do I know it's non-contrast? Look at the aorta. The aorta is isodense. We use density when we describe CT, and it's isodense compared to everything else. So in this case, this is a non-contrast CT. Why do we want to use non-contrast CT? Is because if we use contrast, it will become hyperdense, okay? The stone itself It's calcium, so it will appear white, very bright. So if you use contrast, you're not going to be telling the difference between the blood or the urine and the stone itself. Okay? That's why the gold standard for diagnosing stones and a lot of diseases is non-contrast CT. Now, for tumors, okay, abscess and so on, would you use non-contrast CT or contrast CT? Contrast, okay? So use contrast because a lot of the tumors, as you'll see, is that it will pick up the contrast, okay, because it's hypervascular. So in any contrast CT, you have multiple phases, and it's pretty simple to understand. Phase one, which is the arterial phase, which is when you have the aorta and the arterial system picking up the contrast and the blood itself. Then it goes to the kidneys. Phase two is when it goes into the tissues. Okay, it perfuses the tissues. The contrast is now inside the tissues. Then phase three is when it goes into the urine. So you can clearly tell that the contrast is now in the urinary system. Okay, so you can see it's in the major and minor calyces, or minor and major calyces, and then it's going to go into the ureter. Okay, this is, we use it for diagnosing majority, if not all, tumors. Okay, we use contrast CT. What's very important is, as I said, non-contrast CT is the gold standard for diagnosing stones. Okay, do not pick anything else. Now, MRI, we use it very rarely when we're describing kidney diseases. So it's just a modality that we just have that we can use. It's the best modality when we're trying to visualize soft tissue disorders. However, in terms of renal and urology, it's not really applicable here. Okay. Now, very quickly is we're going to go through simple, like basic embryology that we learned back then in first year, just to explain some certain things, because a lot of the renal embryology things you're going to need to diagnose through just imaging. Okay, but just to understand some of them is when we had embryology, or when we had the development of the kidneys and the rest of the urinary systems, we obviously started off with these three: pronephros, mesonephros, metanephros. The last thing is the metanephros, which is what we actually have as the kidney. Now, the kidneys, when we started developing it, it started off in the pelvis and then ascended upwards. When it's ascending upwards, it interacts with an artery, okay? Now, if it gets stuck on the artery, we have a fusion of the inferior poles, which is what we call horseshoe kidney, okay? Now, any defects in the metanephros itself, whether it's a fusion of this and the metanephric mesenchyme, whatever, you have a renal disease that occurs, congenital renal disease. Now, this is all you need to know. Now we go and actually diagnose these renal diseases. The first one is over here. What can you see on this image? Intrathoracic kidney. Perfect. This over here is the bladder. You can clearly tell that this is the liver. This is the spleen. Okay. This over here is a diaphragm. If it's above the diaphragm, it's intrathoracic. Okay. This is a normal kidney. This is intrathoracic kidney. Okay. This is probably a defect in the ascension of the kidney. It ascended too much and beyond the diaphragm. You just need to identify this image. Okay. This is intrathoracic kidney. How about here? Fused kidneys. Excellent. So the kidneys are going to go to one side and fuse on one side. Okay. So this is what we call cross-fuse ectopia. The kidneys will fuse together in one side. It's going to cross over to one side and fuse. Simple. So this is cross-fuse ectopia. Can you see a kidney on the right side? No. So it crosses over and fuses. Now, how about over here? Pelvic kidney. Okay, good. So this is a pelvic kidney. As I said, is when you had the development of kidneys early on, the metanephros is very low. So it ascends upwards. Okay. As it ascends, if it doesn't ascend too much and stays in the level of the pelvis, then it remains there. Okay. And when it remains there, it's a pelvic kidney. Now, this is, most patients survive with a pelvic kidney, it's fine. It's just more of a incidental finding. Or they can develop renal failure because the blood supply to the kidneys at this level is not going to be as strong as over here. Okay. Again, just for identification purposes, you need to know how these look like because they will come. Okay. So this is pelvic kidney. Now, this is probably the most high yield out of all the congenital renal diseases. Horseshoe kidney. Excellent. So this is horseshoe kidney. Now, when the kidneys are ascending, if you have fusion of the inferior poles of the kidney, okay, and it's ascending upwards, it's going to meet an artery right here. Do you know what artery that is? Inferior mesenteric artery. Good. It goes up and it gets stuck on it. So it can't ascend anymore. Okay. Obviously, it should not be here. It should be a bit above, like normal kidneys. But it gets stuck on the inferior mesenteric artery and it looks like this. Okay. Now, horseshoe kidneys is commonly seen in syndromes. Okay. So most commonly described syndrome is Turner syndrome. Turner syndrome, you'll learn this, I think, a bit in repro. But commonly they have horseshoe kidney. Okay. So that is horseshoe kidneys, and that's it for the congenital renal diseases. Okay. Now we go to this patient. This patient is complaining to you with severe colic pain. Okay. Severe colic pain that starts from the back and radiates all the way to the groin. You ask some further questions. The patient's very dehydrated, maybe went out in the sun a bit, and has some hematuria. What is the diagnosis? Renal stone. Easy. Good. Now, what is the gold standard modality for diagnosing renal stones? Again, CT. What is the most common renal stone? Calcium oxalate. Perfect. Now, what if I told you that this same patient had gout? What type of stone would you suspect? Uric acid stones. Good. Good. What if this patient was taking loop diuretics or thiazides? What stone can happen? It's a tricky question. If it's thiazide, it's calcium or uric acid, both, because it both causes hyperuricemia. Okay? So that's just a trick. Now, what if the patient had cancer? Uric acid. Good. Because of the increased turnover. Good. So the most common stone, 75% of the time, is calcium oxalate stones. It happens usually in the younger age groups. Okay. It's usually commonly due to simple dehydration. Okay. So when you're managing a patient with kidney stones, the main thing that you do is hydrate the patient. Okay. Obviously, there's more into the guidelines and management, and I'll explain some of it, inshallah, at the end of the renal stone part. Now, renal stones can happen anywhere in the urinary tract. It can happen at the level of the kidneys, all the way down in the ureters, all the way to the bladder. Now, at the ureters, there's obviously 3 constriction points. So if it gets constricted over there, you'll have backflow of urine. So this formed what complication over here? Hydronephrosis. Good. Where you have buildup of urine in the kidneys. Okay. Now, this over time will cause either infection to happen or AKI. What type of AKI or acute kidney injury? Post-renal. Good. Perfect. So this is basically that in a nutshell. The first line modality usually that we do is ultrasound, okay? And this is where you can see this hyperechoic lesion with posterior shadowing, okay? Why? Is because all the ultrasound waves will go and get basically attached or stuck onto the stone, and then you're not going to see anything behind it, okay? So this is an ultrasound image. And as I said, this is the most important thing, is that if you're diagnosing a patient with kidney stones, non-contrast CT is the answer. okay? And you can clearly tell on the left kidney that they have a very hyperdense lesion over here, which is a stone, okay, because of calcium. Now, as I said, is that, yes, the first line is usually ultrasound. However, in most cases, if they ask you what do you want to do next, just do the gold standard, which is non-contrast CT. If they're a pregnant female, what will you use? Ultrasound. You won't use contrast CT or non-contrast CT, sorry. You will not use CT because radiation. So now you have these four types of stones. You have calcium, which the most common type is calcium oxalate stones. Again, it's radio opaque. CT findings is it's hyperdense. Now, the thing is that you need to identify these stones as well when it comes to the shape of the urine crystals itself. Now, calcium oxalate looks like an envelope, as you can see here. Okay, so that's one way to identify it. Usually they put this in the MCQ stem. So that's that. Now, this type of stone, which is struvite stone, has a characteristic structure to it, which is, it looks like horns, okay? And it fills up the entire kidney. It's very huge. What organism causes struvite stone? Proteus mirabilis. Why? What is the one virulence factor that it has that could cause it? Urease positive. Excellent. Which will alkalinize the urine. Okay, makes it very alkaline, and this causes the precipitation, okay, of ammonium magnesium phosphate. So this is a struvite stone or a staghorn calculi. It's radiopaque. However, you're not going to really diagnose it through X-ray. It's hyperdense on imaging, obviously. Now, for the urine crystals, it looks like a coffin lid, okay? So now these stones, the uric acid, the struvite stone, sorry, is very big. So when you treat it, you don't really use the normal treatments that you do for the stones, which I'll get to it. You need to eradicate it from outside, okay? You use, for example, lithotripsy to break down the stone from outside or surgical removal, okay? Because it's very big. Yeah? Now, usually because it's caused by Proteus, is you need to treat the underlying infection as well. Now, uric acid, it's obviously associated with hyperuricemia and anything that causes hyperuricemia. And the urine crystal associated with it is rhomboid shaped, as you can see. And it's a very small proportion of stones. Now, lastly, which is a very rare genetic type, which is cystine, which is because of cystinuria. Now, cystinuria is basically because you have a defect in the absorption of some amino acids, which are these. So cysteine, ornithine, lysine, and arginine, okay? Because they're poorly absorbed, they precipitate in the urine, forming cystine stones, okay? Now here, it looks like a hexagon. That's how you can identify it using crystals. Now it comes to the management of the stones. The magic number that I want you to remember is 5 millimeters. Usually below 5 millimeters, the stone size, if it's below 5 millimeters, it passes on its own. So you give the patient, just hydrate the patient, tell them just drink water, go home, and it will go out on its own. If it's between 5 and 10 millimeters, okay, this case is you need to hydrate the patient. Most likely, it will go out on its own. However, you might need to also give them certain agents, such as alpha-1 agonists, to dilate the ureter. If it dilates, it passes through. Okay? Now, if it's above 10, this is when it's too big to pass on its own, or the ureter itself cannot be dilated more than that. So what do you need to do? Call urology. Okay? Surgical. Either lithotripsy from outside or surgical removal, urethral or from outside, okay? Whatever the case. So the management, first line usually is just hydrate the patient, and usually it will pass on its own. If it's too big or causes complications, then you need to obviously go through more difficult managements, such as lithotripsy, which is radiation, or the external shockwave lithotripsy, or you can use surgery, okay? So that's basically that. Now, what are complications, you might ask, is if the patient, us normally, we have two kidneys. If the patient had a stone in one kidney, the other kidney will compensate. So you won't have acute kidney injury. If in the case that you have one kidney or patients with one kidney, if they have a stone, this will cause renal damage and renal failure. Okay, because the other kidney cannot compensate anymore. That's number one. Number two is that because of the stone lodging in the ureter, for example, and causes hydronephrosis, this might cause infection. So if you have infection, the patient later on might might have sepsis. Okay, so that's another one. And then with sepsis, you have hemodynamic instability and so on. These are all signs of complicated stone. Okay, so that's basically kidney stones all in a nutshell. Is everything clear till now? Tamam. Now, what type of stone is this? This is very important to diagnose by imaging. Staghorn or struvite calculus. Again, how would you want to treat? Do you want to treat conservatively or would you want to do surgery? Surgery, good. What organism causes it? Proteus, good. And is the urine acidic or alkaline? Alkaline, good, perfect. That's it. Now we go to the cystic renal diseases. The first one is this. This one, all you need to do is identify it. I'll give you the one key term. What type of renal cyst or cystic disease is this? Multicystic renal dysplasia. Now, what is one important composition of this renal cyst that differentiates it from all other? Cartilage. Good. Once you hear the word cartilage in a renal cyst case, you go for multicystic renal dysplasia. And it's very huge cysts, as you can clearly tell over here, and you can see some cartilaginous structures. Okay, this is very important for you to remember. Just cartilage. That is one key term that will get thrown. You pick this immediately. Okay. Now, you have a patient who is 45 years of age, presenting to you with hypertension, very severe hypertension, headaches, right upper quadrant pain. What is your diagnosis? Autosomal dominant polycystic kidney disease. Excellent, good. So ADPKD, okay, autosomal dominant polycystic kidney disease is a cystic renal disease that occurs in adults, usually during the fourth to fifth generation, okay, or decades, which is around 40s to 50s, and usually presents with hypertension, headaches. Why headaches? Berry aneurysm, perfect. And also could present with right upper quadrant pain. Why? Hepatic cysts, good. Liver cysts, good. Now, these patients also will have hematuria, renal failure eventually, and so on. Now, these cysts are very, very large, okay? I'm very sorry, by the way, for the background noise. A lot is happening around me. But anyways, is the audio clear, by the way, for you guys? Tamam. Okay, it's very big cysts and it's bilateral. Tamam. This is very important because you need to differentiate it with another cystic disease. Okay, and it's usually the cysts that are formed from the proximal convoluted tubule. Now over here, you can see some stones that are forming in the kidneys as well. Tamam. So this is autosomal dominant polycystic kidney disease. Now, the gene. What is the gene associated with ADPKD? PKD1 and 2, which one is the more common and more severe one? 1, which encodes for what? Encodes for polycystin 1. Perfect. Good. So this is ADPKD. Usually in the case, it's described to you as this type of patient with hypertension and so on, usually in the fourth to fifth decade, and then usually has someone in the family with the same things. Okay. Now, if you do imaging, whether it's ultrasound or a CT, is you can clearly tell that the cysts are huge and bilateral. Okay. Very big cysts. You cannot, it's very distorted kidney and bilateral. This is autosomal dominant polycystic kidney disease. Tamam. How about this? child, you do ultrasound for the mother and you diagnose this intrapartum. What is this? Autosomal recessive polycystic kidney disease. Good. Now, autosomal recessive polycystic kidney disease happens usually in newborns, in neonates, and it's associated with renal cysts. Okay. Now, these cysts originate from the collecting ducts. Tamam? So hence why is that the cortex itself is not usually as affected. The kidneys itself will be cystic. However, the cortex and the externally will be smooth. Tamam? And it's obviously always going to be described to you in an infant. And death is usually, unfortunately, in utero, okay, with autosomal recessive. From the proximal convoluted tubule. AD from the proximal convoluted tubule. Usually, I don't think it was mentioned, but that's a fun fact for you. That's why the cortex and medulla, or the cortex itself, cysts are everywhere, okay? Now, for autosomal recessive, is associated with a gene. What is the gene associated? PKHD, perfect, 1, which is encodes for what? Fibrocystin, perfect. So these are basically the polycystic kidney diseases. Okay, and I have a cameo from Yazan. Anyways, that is basically the kidney diseases or the polycystic kidney diseases. Okay, important thing also for the autosomal dominant is death is usually obviously number 1 is due to the renal failure that will happen, and number 2 is because of the berry aneurysm rupture and cause of subarachnoid hemorrhage. Okay. So in this case, what form of polycystic kidney disease is in this patient? Autosomal recessive. Good. Small, yeah, smooth kidneys. You can see numerous cysts, some cysts over here, but here in the CT, it's more clear. You can see a lot of cysts developing, but the external part of the kidney is very smooth. This is autosomal recessive polycystic kidney disease. Now you have this patient. Numerous cysts that only involves the medulla. Medullary sponge kidney. Good. All you need to know is that it's from the collecting ducts from the medulla. That's all you need to know. Okay, about medullary sponge kidney. Most of your questions in this lecture will be about autosomal recessive PKD and also autosomal dominant PKD. The rest is not usually as high yield. Now, how about over here? Sponge again. Okay. What's the purpose of this image? Is it affecting the cortex? No, it's only affecting the medulla. Perfect. And this lesion also over here is commonly described as popcorn lesions, okay, in medullary sponge kidney. So that's basically that. It's from the collecting ducts in the medulla, does not involve the cortex at all. Yeah, that's medullary sponge kidney. Now, how about over here? Another medullary cystic kidney, but I just gave you like the actual diagnosis. It's another cystic disease that's developing from the medulla. Simple, okay? Now here it's not as numerous as the medullary sponge kidney. And also over here is associated with genes, okay? So there's 2 genetic syndromes, if you want to call it that, associated with medullary cystic kidney. Number 1 is juvenile nephrosis or whatever it's called. Now in this one, it's associated with 3 gene mutations, which are what? NPH1, 2, and 3. Perfect. The other one, which is medullary cystic kidney, which is this one in itself, what genes? MCKD1 and 2. Perfect. This is basically medullary cystic kidney. Now over here, you had a patient with renal failure that then developed numerous cysts. So this is dialysis associated cysts. Now, in a patient with chronic kidney disease, they might be or they usually are on dialysis. Okay. Now, with dialysis, one of the complications very rarely that can occur is cysts. And you can see clearly tell here that there are numerous cysts in the kidneys. Okay. Now, how about over here? What is this that you can see on these images? Cyst. Is it one cyst or many cysts? Obviously, look at this image. One singular cyst. Good. Now, how do you classify cysts? Simple versus complex cyst. How do you tell the difference between them? Is we use a certain classification system, and I'll teach you guys in a second. But in this case over here, do you suspect this to be a simple cyst or a complex cyst? Simple cyst, okay? Do you see any septations or septa in the cyst? Yes or no? No. Do you see any calcification around it? No. Do you see any tissues around it, in it itself? No. This is completely anechoic. Anechoic, it doesn't pick up the ultrasound waves. And you can clearly tell right posterior to it is posterior acoustic enhancement, okay? Which is because the sound waves will pass through this fluid-filled cyst and then will enhance further posterior to it, okay? Now, if you do CT, as you can clearly tell over here, you have one septa. This is a very benign cyst, or most likely benign cyst. So in this case, we don't really worry much, okay? So this is a renal cyst. Now, the classification system that I want you guys to know is the Bosniak classification. It's very simple, and I'll tell you it now. So Bosniak 1 is similar to this cyst over here. No septations, no calcifications, no masses inside. If it fits all these three, simple cyst. Okay? Bosniak 1. Do you need to further biopsy it? Do you need to take it out? Yes or no? No. You leave it. It's benign. Bosniak 2 is when you have few septations, okay, that are very thin. So this is Bosniak 2. This patient over here, what do you suspect this Bosniak classification to be? 2. Simple, okay? Bosniak 2F has many septations, or one or more many septations, but these septations are larger than 3 millimeters in width. So it's a lot thicker septations, okay? Bosniak 3 is huge irregular septations, okay? Huge being more than 4 millimeters. The simplest one is Bosniak 4. Is you can clearly tell there's tissue inside the cyst or the nodule itself. If you start to see cyst tissue or any masses inside the cyst itself, then you can clearly say that this is Bosniak 4. What do you need to do next? Biopsy. Okay, take it out. And further imaging, obviously. 3 and 4 are suspicious. You need to do further investigations for it. 1, 2, 2F, usually you don't do a lot. Tamam? 1 and 2 specifically, you don't do a lot. 2F, you can do further imaging. 3 and 4, you need to investigate it further, biopsy and whatnot. Tamam? Now we'll practice. Here in this case, what do you think is the Bosniak classification? So in this case, actually, it's Bosniak 2. This calcification around it shouldn't be happening. Tamam? And you can clearly tell over here you have septation. Yes or no? Yeah. So this is Bosniak 2. Is it more than 3 septations? No. Is the septation very wide? Just imagine it's 2 millimeters. It's 2 millimeters. It's thin. So you can clearly say this is Bosniak 2. How about over here? Thick, irregular septations. Bosniak 3. Perfect. Thick and irregular septations. Here, if you look at this septation, it's regular. It's just one line. Here, it's irregular. It goes everywhere. So this is Bosniak 3. What do you want to do in this case? Do you want to leave it, or do you want to do biopsy or further investigation? Biopsy. Good. How about here? Clear density in the cyst. Bosniak 4. Good. This is very suspicious. So you need to do more. Tamam? This is Bosniak 4. Now in this case, what is this type of cyst in pathology? Simple cyst. Usually the size is around 5 millimeters up to 5 millimeter. Sorry, not millimeters, centimeters. It's fine. Okay. Above that, with the subtations and or tissues that you find inside the cyst, this is more complex. Okay. So this is simple cyst. So until now, is everything good? No. Now, what is this? You have a patient who has a lot of skin lesions, okay, epilepsy or seizures, presenting to you incidentally with these renal findings. Okay. This is an angiomyolipoma. These black structures in the mass itself are what? Lipids. Okay. Lipids are black on CT. Okay. So if you see these black lesions in an area of many densities, okay, this is an angiomyolipoma. Angiomyolipomas are benign. تمام? But it's commonly seen in a genetic syndrome, which is what? Tuberous sclerosis. Good. So how does tuberous sclerosis actually present with? You don't need to know the details of it. You just need to know in a patient with angiomyolipoma, it is associated with tuberous sclerosis. But tuberous sclerosis itself has a lot of skin lesions. Okay. So usually it's skin lesions on the face. There's a lot of lesions in the back as well. It's, for example, on the face, it's called angiofibromas. In the back, it's called like ash leaf spots and whatnot. Also, commonly, they have heart tumors as well and hamartomas everywhere. Okay. Angiomyolipoma, which is a tumor of three different structures, blood vessel, smooth muscles, and lipids, is commonly seen in tuberous sclerosis. Okay. So when you take biopsy and you actually look into it in the microscope, what do you see? What are these? Blood vessels. What are these? Lipids. And then what are these striations? Muscle spindles. Good. Muscles. So now if I ask you, again, angiomyolipoma, what genetic syndrome? Tuberous sclerosis. Good. Very high yield. Now, this tumor has a central scar. This is the only keyword that you need to know. Renal oncocytoma. Good. So renal oncocytoma, the important thing about it is this central scar. Okay. In the question stems, they will put that for you guys, inshallah. Is that central scar? Because otherwise you're not going to be able to tell the difference between these tumors. So the key term here for oncocytoma is the scar. Okay. Now, if you do, and this is the central stellate scar in histology. Now, this tumor is very rich in mitochondria. Also, another thing that you need to remember, okay, about it, is it's very rich in mitochondria. That's it for renal oncocytoma. How do you diagnose it, or like what is the key term? Central stellate scar. Okay, you get that in a question stem, renal oncocytoma. Now, you have an infant with this mass, very big mass in the kidney. What is this tumor? Wilms tumor. Good. So Wilms tumor or nephroblastoma is a childhood. It's one of the childhood small cell or blue cell tumors, the neuroendocrine tumors, and it occurs in the kidney. Okay. It's one of the most common like pediatric tumors. And in this case, it affects the kidneys. All you need to know is basically what I just mentioned. On an imaging, you can see a very big mass, okay? Can affect either kidney. In this case, this is the left kidney that's affected, and this is the right kidney that's affected. Or sorry, this is the right kidney, this is the left kidney, okay? In this case, the right kidney is normal. So, this is a nephroblastoma or Wilms tumor. Now, how about this patient? Let's just say a 50-year-old smoker who presents to you complaining of painless hematuria with palpable abdominal mass and flank pain. Renal cell carcinoma. Good. Renal cell carcinoma. Good. Now, what if I told you this patient also had bone pain and hypercalcemia? Why do they have it? Bone pain and hypercalcemia. Not osteodystrophy. PTH. Good. Why? Because of paraneoplastic syndrome. Okay. There's 4 paraneoplastic syndromes associated with RCC, renal cell carcinoma. Number 1 is PTH, hyperparathyroidism due to PTH-related peptide. Number 2, which is very high yield for you guys, is what if their hemoglobin is very high? This is polycythemia because it produces erythropoietin. Good. Now, what if they also have Cushing syndrome? Why? ACTH. Good. Now, also, one other thing is hypertension. Why do they have hypertension? Renal. Good. Right. So this tumor is associated with a paraneoplastic syndrome, which secretes, number 1 is PTHrP, so it causes hyperparathyroidism. Number 2 is erythropoietin, so it causes polycythemia. Number 3 is it secretes ACTH, so it causes Cushing's. And number 4 is it secretes renin, so it causes hypertension. The key description here for this is painless hematuria with flank pain and a palpable abdominal mass. This is RCC. Now, is there a tumor syndrome associated with RCC? Genetic syndrome. The most common one that I want you to remember is VHL, von Hippel-Lindau syndrome. Okay. Usually these patients present with hemangiomas, cerebellar lesions, and then clear cell renal cell carcinoma, and one other one, which is pheochromocytoma. Okay. So this is VHL in patient with renal cell carcinoma. Okay. Now, renal cell carcinoma. What if this patient suddenly develops a varicocele? Suddenly. What do you suspect? Why? RCC. If a patient suddenly presents with a varicocele, you suspect RCC. Why? Like, good. Obstruction of the left renal vein. Good. So the gonads, the testes, you have the left and right gonadal vein, right? The right gonadal vein drains into what directly? The inferior vena cava. Good. The left gonadal vein drains into what? Left renal vein. This tumor loves to spread hematogenously through the venous system. So when it goes to the venous system and blocks the left renal vein, what vein will be dilated afterwards? Because of obstruction of left renal vein, the left gonadal vein. So in this case, it will cause varicocele. Okay. So if you have a patient with these signs of RCC, which is the flank pain, painless hematuria, and whatnot, with a varicocele, you suspect RCC. This is RCC, and we mentioned everything, inshallah, about it. Now, in this case, there's many stages of RCC. There's 4 stages as you stage any tumor. Now, here, in this case, it's a small tumor, RCC. In this case, you can treat it with something called a partial nephrectomy, which is basically you just remove that portion of the kidney. You spare the rest of it. Now, in later stages, no, you kind of need to remove the entire kidney. So radical nephrectomy, and you need to give them chemoradio afterwards. Now, in this case, this is stage 3, which invades into the left renal vein, okay? Or the renal vein itself. Now, here, stage 4, as you can see, there is metastasis. Now, what is a very common area of metastasis for renal cancer? The most common, lungs. Remember lungs, okay? And it can cause, yes, exactly, the cannonball appearance when you do an X-ray, the lungs. Another important point of metastasis for RCC, as I said, the left renal vein. If it presents as a varicocele, you suspect RCC. So that's basically that. Now, on gross imaging, What color is the tumor? Yellow, golden, or white appearance. Okay, that's basically all you need to know in a patient with the signs and symptoms, as I mentioned. Now you have two histological subtypes of RCC. Number one, which is the most common, is this. What histological subtype is this? Clear cell. Good. Why is it clear cell? As you can clearly tell, the cells are clear. Okay, so clear cell, renal cell carcinoma. This is most likely associated with VHL. Okay, how about here? What form or subtype of RCC is this? Good. So you have finger-like projection with a fibrovascular core. Okay, this is a papilla. What are these that you can see here? Some of them about these. Perfect. This is papillary renal cell carcinoma. The most common one is clear cell. Okay. So this is basically everything that we mentioned already. But again, just so you guys have, in case like I missed something, but we mentioned all the perineoplastic syndromes, we mentioned clear cell, and then we mentioned how the patient would present with. Okay. This is very high yield. You will get many questions on RCC. Okay. Now we have another form of renal cancer or renal tumors, which is this. What form? Okay. So what lines the minor major calces plus the urothelium? Transitional cell. Okay, urothelium. So this is transitional cell carcinoma or renal urothelial carcinoma. Okay. So in this case, this is in the renal pelvis. Okay, and it causes a filling defect. Okay. In this case, this filling defect, which is this defect, is a mass. So you suspect urothelial carcinoma. Here's another image of it. So usually it should fill out the entire pelvis, and obviously there's dilation in this case. However, there's a filling defect, which is all of this mass. In this case, you suspect renal urothelial carcinoma. Here in this patient, they have bilateral filling defect in the ureters. So this is urothelial carcinoma. Urothelial carcinoma, we'll talk about more when we go to the bladder, okay? Because it's the most common tumor there. And I'll mention the risk factors and how that presents. In this case, renal urothelial carcinoma, just the presentation of it is it presents with massive hematuria, okay? So that's basically that. Here is another one. You can clearly tell that it's coming from the major and minor calyces. Here in this case, it's a major calyces. And you can clearly tell there's urothelium, okay? So this is renal transitional cell carcinoma or urothelial cell carcinoma. Now, how about this patient? What do they have? This one. This is both of them, lymphoma. Okay. In a patient with a known case of lymphoma that then metastasizes to the kidneys will present as this. Why do you suspect lymphoma and not cysts in this case? Or cystic kidney diseases? It's enhanced. Good, good. So there is density here. If there's density, if it's enhanced in cyst, there's no enhancement. In this case, there's enhancement. So in this case, you start to suspect lymphoma in a patient with already known case of lymphoma. In this case, this image, memorize it. This one, memorize it very well. Okay. This is renal lymphoma. Again, in radiology, anything that was in red, know by heart, because you'll get questions on it. So that's basically that. Now patient, this patient had hypertension that wouldn't go away. You do imaging and you can clearly tell there's some defect in the renal artery. What is this? In both of them. Renal artery stenosis. Good. Now, the most common cause of renal artery stenosis is atherosclerosis. Which one over here, which one of these two do you suspect is atherosclerosis? This one. Good. Why? Osteostenosis, very good, mashallah. Good. Osteostenosis or proximal stenosis. Okay. Proximal or osteal, which is the opening of the renal artery, is where you have usually the atherosclerosis build up over here. Okay. This is causes the renal artery stenosis. In this case, female patient, middle age, recurring headaches, hypertension. What do you suspect this disease is? It's a form of vasculitis. I'll give you a hint. Fibromuscular dysplasia. So it commonly affects not the ostia of the artery or the opening or the proximal part. It usually affects the distal 2/3. Okay. And it forms these beading appearances. So this is fibromuscular dysplasia. This is atherosclerosis. Now, the last thing in the kidneys, before we move on to the rest of the organs, is renal trauma. Renal trauma can obviously affect bleed and cause bleeding of the kidneys and surrounding the kidneys. But it's very important to know the grading system just for the management. Do you need to know it in detail? Just know one thing about each of these grades just to kind of picture what's happening. Okay, so the thing that you need to remember about it is how much it affects the renal cortex. Does it go deep to the medulla, or does it affect what's it called? Does it leave the capsule of the kidney? Okay, these are the things you need to keep in mind. So if it only affects right next to the cortex and it's a hematoma in the capsule, what grade is this? 1. If it's just a subcapsular hematoma right below the capsule of the kidney, then this is grade 1. Okay. If it goes into the cortex, this one does not go to the cortex, it's just on the capsule. Grade 2, if it goes just into the cortex, less than 1 centimeter into the cortex. If it's grade 3, it goes deep, more than 1 centimeter into the cortex. Okay, simple. Grade 4 is it goes into the renal cortex, into the medulla, into the collecting system. Okay. Grade 5 is shattered. Tamam? Now to test you guys. If I have a renal injury, trauma, that goes 3 centimeters into the renal cortex, does not affect the medulla, what grade is this? 3 centimeters into the cortex does not affect the medulla. 3. 3. It's more than 1 centimeter depth into the cortex. Okay? A shattered kidney. 5. Good. Only a subcapsular hematoma. 1. A laceration that goes all the way to the renal pelvis. 4. Is renal trauma clear? Yes, good. Why is this important? Grades 1, 2, 3, conservative management. 4, 5, no, you need to do something about it, and usually you remove the kidney. Okay? That's why it's important. Now, last thing over here, I think this is the last slide of the kidneys, is what's happening over here. You have a wedge-shaped structure over here. Necrosis or infarction. Good. Usually anything that is wedge-shaped, okay, in an image where it becomes hyperdense to hypodense like this is an infarction. This is because of cutoff of blood supply. Very simple. Okay. We're done with the kidneys. Any question till now? Okay. Let's take a 5-minute break. Let's resume at 8:05. And the rest of it I'll go in one go. Is that okay? Tell. Okay, so now we're gonna go over all the ureter and bladder disorders. Now, ureter, just one thing, which is, what is this? Let's just say someone with chronic inflammation of the ureter. What do they develop? These small little cysts. So what do I call this disorder? Uretritis, and then because of their cysts, uretritis cystica. That's it. Okay, very simple. Now for the normal urinary bladder. What is the lining of the bladder? Give me the epithelium. Urothelium, which is transitional cell. Good. Now, this is a section of the bladder. What are these nests called over here? Von Brunn nests. Good. Which is basically an invagination of the urothelium into the lamina propria. The only thing you need to know is just to identify it. There's not really much clinical significance at all here. Okay? Now we go into some congenital anomalies of the bladder. Now, in this case, the whole entire bladder is outside. So what do we call this? On the surface of the body. Extrophy. Good. What is the significance of bladder extrophy? What can it lead to? Adenocarcinoma. Good. Perfect. Now over here, what is happening with the bladder? Diverticulum, which is outpouching of the mucosa or whatever outside. That's it. You'll learn this more in GI, what diverticula is, like in detail. But the thing about diverticula in the bladder is there's two types. There's either acquired or congenital. Acquired diverticula is usually due to bladder outlet obstruction. Okay, it builds up a lot of urine over here, so it starts to outpouch. Okay, and it's commonly seen in BPH. Congenital is from birth. That's it. Simple as that. It doesn't increase the risk of cancer as much. Yeah, that's diverticula. Now, how about over here? There's communication from the umbilicus to the bladder dome. What is this? Direct communication. Patent uricus. Good. Usually how it's described is urine will come from the umbilicus. That's it. Simple. Patent uricus. How about over here? Urachal cyst. Good. So this is the urachal cyst. What's significant about it? Adenocarcinoma. Good. Now, what is the precursor for adenocarcinoma in the bladder from the urachal cyst? Do you guys know? Villus adenoma, which is what's happening here. Good. So what happens in urachal cyst is that can form villus adenoma. Now, this villus adenoma is a risk factor for what type of cancer? Adenocarcinoma. Simple. Okay? Because it's an adenoma. Glands. So this is villus adenoma. How do I say it's villus? It's finger-like projections. And this later on develops into adenocarcinoma. So this is all that you need to know about the congenital bladder stuff. Okay. Now we go to this. Now in this patient over here, we had a patient who had cancer, and we treated them with cyclophosphamide. What's happening with the bladder? Hemorrhagic cystitis. Good. Keyword, and it's usually always given to you, is this patient is taking cyclophosphamide. Okay, it can happen due to other things such as trauma, adenoviral infection, but the most important thing to remember is cyclophosphamide. Hemorrhagic cystitis. What's wrong with hemorrhagic cystitis is, as I said, it can predispose patients to cancer. Okay, usually urothelial cancer. Now you have this patient who has something called chronic pelvic pain syndrome. Okay, so chronic pelvic pain syndrome, or what this patient has, is basically where they have chronic dysuria. Dysuria is pain when urination because of a lower urinary tract infection or inflammation. Okay, so in this case, they have chronic infection. So what is this patient have specifically? Chronic cystitis with what feature? Cyst. No, not cyst. What are these? The invagination of the epithelium into the lamina propria. Von Brunn next. Good. So this is cystitis cystica, or in other words, chronic cystitis, okay? That formed because of long-standing inflammation. Okay, this is also called chronic pelvic pain syndrome. I don't know if that was mentioned, but that's a fun fact. And the histological feature of early stages of it is von Brunn nests. That's it. Later on, it forms glands and so on. Okay, so it then forms glandularis, as you can see, chronic cystitis cystica with glands. Okay, you can clearly tell glands are forming here. That's all you need to know about cystitis cystica. Now, this is another thing actually, is what finding do you see on this image in a patient with cystitis cystica? Malakoplakia, good. Malakoplakia is due to a defect in what immune function? Phagocytosis, good. So with the defect of phagocytosis in malakoplakia, you have the organisms or whatnot build up inside the cells, right? So it forms this. Now, what do we call these bodies? Nicalis gunman, I think. Gutman bodies. KGT bodies. MG bodies, sorry. So these are MG bodies, which are the target lesions, okay, which is because of accumulation of the organisms inside the lysosomes, okay, because of phagocytosis dysfunction, okay. This is malakoplakia seen in cystitis cystica. Usually, they'll bring this in the exam. Okay? Malakoplakia, specifically for you to diagnose cystitis cystica. It's very easy to identify it through that. تمام? Now, with long-standing bladder outlet obstruction, okay, you have this forming in the bladder. What's forming in the bladder? Trabeculations. Good. So two things can happen because of multiple things, actually, a lot of things that can happen due to bladder outlet obstruction. Number one, easy, because if you have stagnation of urine in the bladder, you have increased disposition to infections. That's number one. Number two, stones. Number three, diverticula. Number four, trabeculations. Okay, you can remember a lot more, but there's a lot more, but these are four that you want to remember. Infection, stones, diverticula, and trabeculations. Okay, this is bladder trabeculations. Because of long-standing dilation of the bladder, stretching of the bladder, it starts to form these trabeculations. Now, you have a patient, smoker, presents with painless hematuria, no abdominal findings. Urothelial carcinoma, transitional cell carcinoma, most common type of bladder cancer. The most important risk factor is smoking, 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 smoking. Okay, I said it multiple times, smoking, and usually presents as painless hematuria. They don't have other features of RCC, the triad. They don't have flank pain. They don't have abdominal, palpable abdominal mass. They have none of that. They have painless hematuria in a smoker. First differential that you think of is urothelial carcinoma. Now, there's other risk factors for use for transitional cell carcinoma or urothelial cell carcinoma of the bladder. For example, certain dyes can form it, medications such as cyclophosphamide. And then you can have one infectious organism that might cause it, which is what? Might. Schistosoma hematobium. What cancer is mostly associated with schistosoma? Squamous cell carcinoma. Good. So squamous cell carcinoma, if you want to think of a risk factor, think schistosoma. Okay. The rest is all going to cause urothelial cell carcinoma. تمام. Here it is in imaging. You can see a filling defect, and then you can see some calcifications and very ugly signs on CT. تمام. This is bladder urothelial cell carcinoma. Now over here, it usually looks like a fungating mass on gross imaging. And you can clearly tell it's very, there's some necrosis and anaplastic cells that are occurring here. And then here you can clearly tell that it is papillary. So that's basically urothelial carcinoma. And that's it for the bladder. We're going to finish the session, my fastest session ever. Okay. So now, until now, we good? Any questions for the bladder or ureter? We're all clear. As I said, this session is very just identification and key terms. So just a bit on the management, I guess, if you really want to, of bladder urothelial carcinoma, it's usually you remove it. Okay, you do, for example, transurethral resection if it's early stage, but you do imaging and so on if it's invading the bladder wall. Then you do radical cystectomy, which remove the whole bladder and surrounding structures, and neoadjuvant therapy. Now, there's one specific thing that you can do, which is intravesical injection of what? Inside the BCG. Okay, good. So one fun fact, we don't usually do it, is that you can inject BCG, which is if you know, the vaccine for TB, inside the uh, inside the bladder at the site of the tumor, and this shrinks the tumor somehow. Okay. But anyways, this is all fun facts. I doubt you're gonna get asked that. What you will get asked that is diagnosis. Okay. You need to know how it presents and the risk factors. Those are very important, key, and very crucial for you to remember. Now we go to the prostate, which is very simple, inshallah. The most important thing is that you have two structures in the prostate. Number one is the epithelium, then the stroma. Okay. The epithelium, how many layers of the epithelium do we have in the prostate? Two. Any changes to this is abnormal. Just remember that. Any changes from 2 to 1, 2 to more than 2 is abnormal. You need to have 2. The other thing is, what's this thing in the secretions of the prostate? Do you remember from second year? No. This is a way you can, it's protein, it's corpus amylacea. Okay. Anyways, it's for you to know that this is the prostate. And then you have the stroma. Okay. Now, one way we can diagnose prostatic diseases is MRI. Okay. Now, think of this MRI as if you're looking from on top. Yeah. Now, what is this structure over here? Rectum. Excellent. What is this structure? Prostate. Perfect. Now, what type of MRI is this? Is this T1 or T2 weighted image? T2. What tells you that this is a T2 weighted image? Good. So this is peripheral hyperintensity. Okay. So this is BP. This is normal prostate. The periphery of the prostate is more hyperintense. It's brighter. Okay. The central part of the prostate is darker. This is a normal prostate MRI. Now, what do you see here? You have a patient who's presenting to you with chronic long-standing difficulty urination, dribbling of urine, and then later on developed post-renal AKI. And then the bladder, they had trabeculations, recurring cystitis, stones, and whatnot. What is the diagnosis? Benign prostatic hyperplasia, simple. Okay. What zone of the prostate is affected in BPH? Transitional zone, or what's another term we give transitional zone? Central, which surrounds what structure? Urethra. Good. So easily, because of this, it causes obstruction. Done. So all the symptoms is because of overflow incontinence, which is overflow of urine in the, or sorry, not incontinence, but overflow of urine in the bladder. Okay. So you have difficulty initiating urination, dribbling of urine, recurring cystitis, maybe dysuria, all these things. If you do MRI, you can clearly tell that it's, what's it called? Very big central zone of the prostate. And there's no hyperintensity in the periphery. There's no masses in the periphery. Another thing is it's nodular. Now, if you do a digital rectal examination, the prostate itself, is it going to feel rubbery or very hard? Rubbery. Good. Will you feel one mass, one solid mass, or multiple nodules from the name? Multiple. Good. Okay, now, what's one important blood lab marker that will be elevated in BPH sometimes? PSA. What's the cutoff number? 4. Remember these two numbers, 4 and 10. If it's more than 4, it might tell you that this is BPH. If it's less than 4, does it exclude BPH? No. Good. If it's more than 10, what does this signifies? More than 10. Maybe cancer. Good. If it's less than 10 or less than 4, does it exclude cancer? No. Good. This is BPH. Now, how about over here? There's a question in the chat. What do you mean the other thing about the imaging? So I don't remember what I just said. I'll explain I'll explain this when I get to cancer. Don't worry. Okay. Here, in this case, you have clear BPH. Now, what complications are occurring here? Stone. Good. Perfect. Why? Is because you have stagnation of the urine. Easy. This is BPH. Now, in BPH, you have hyperplasia of two things, which is what? Stroma and glands. That's it. This is the definition of BPH. Good. So you have proliferation of the glands itself and the stroma. تمام? This is BPH. Now, for the treatment of BPH, you firstly can do just watchful waiting if the patient's not really that symptomatic. Then you have medical treatment, and then you have surgical treatment if it's very severe. تمام? Now, think about it logically, is if you want to treat obstruction, you dilate. That is basically the gist of the management of BPH. Now, how do you dilate? You can use alpha antagonists. Okay. I said before alpha agonists for the ureter, I meant alpha antagonists. Okay. So you have alpha antagonists, such as tamsulosin or whatever. Now, here in this case, if you have alpha 1, will constrict or dilate. If you have agonist to alpha 1, constrict. So you block that, you cause dilation. That's basically that. So these are selective. These three are selective. These are not selective. And if you remember from CVP, when I mentioned that you can use prazosin for hypertension with BPH because it causes non-selective antagonism. تمام? As non-selective antagonists, they cause postural hypotension. Okay. And then, as I mentioned, hypertension plus BPH, which is a common scenario that you will get, is if a patient has both of these, you give one of these drugs. تمام? And these are some of the adverse effects. Okay. And it's all because of the alpha 1 antagonistic effect. تمام? Then we have two important, this one, it depends on, now in the prostate itself, what will control the hyperplasia of the prostate is dihydrotestosterone. Okay. So what you do for dihydrotestosterone is you inhibit it, okay, by 5-alpha reductase, which is finasteride, which use finasteride, which inhibits dihydrotestosterone, which inhibits the 5-alpha reductase, which will reduce dihydrotestosterone. It's simple. So that's basically finasteride for you. Another thing is the use of finasteride is in male pattern baldness, if you want to remember. Now, phosphodiesterase inhibitors, basically, it causes a buildup of cyclic GMP, and this will then lead to increased nitric oxide, which dilates. Simple. So it relaxes the smooth muscle in the prostate and the bladder. This is the phosphodiesterase inhibitors. Now, in this case, you cannot use this with nitrates, okay? So if a patient had, let's just say MI, okay, and they're taking nitrates, can you give this medication? No. Why? It could cause extreme hypotension. Its indication use erectile dysfunction because it causes dilation. Pulmonary artery hypertension, you guys learned this in CVP, and then now BPH. Okay, now so adverse effects is because of dilation, headache in the cerebrum, indigestion, flushing, nasal congestion, all because of dilation. That's basically the BPH drugs. Now, this patient is an African American patient and had family history of a certain cancer. And you do MRI, which is T2 because the periphery is bright, and you can see a lesion in the white area of the prostate. What is this? Prostate adenocarcinoma. Why do I say this is the posterior part or the peripheral zone of the prostate? Why can I tell that this is in the peripheral zone? Look at the peripheral zone. It's brighter than here in T2. Where is this tumor? In the brighter area. So this is a lesion in the peripheral zone. So it's brighter than the rest of the prostate. Okay, which is the central zone over here. This is the peripheral zone. Okay, this is a lesion in the peripheral zone. Okay, good. Now, in this case, if you do a DRE, is it going to be hard or rubbery? Hard, good. And what's one tumor marker you want to order? PSA. Will negative PSA exclude your diagnosis? No, good. Now, some risk factors for prostate adenocarcinoma is, for example, African American or Hispanic males, I think, for the demographics. Then you have environmental causes, which causes hypermethylation. Okay, that's a very important one. Then we have some genetic involvement, which is mixed gene mutation. And yes, the thing that gets hypermethylated is the GSTP thing. Good. And then some somatic mutations can also occur. Okay, this is prostate adenocarcinoma in a nutshell. Okay, good. Here, where is a tumor located? Just simple. The central zone, which is this, is normal. You can clearly tell the urethra is not obstructed. So where is this tumor? Peripheral zone. Good. How do these patients present? Usually asymptomatic. And then it causes symptoms when it spreads. Where are the two areas that are important to spread for prostate cancer? Bone, and you can say brain, that's fine. But perineural, okay? It goes through the nerves. Tamam? Now, in the bone, what type of metastatic lesions do you see in prostate cancer? Osteoblastic lesions. Good. Perfect. Now here, in this case, you can have, for example, you can clearly tell how many layers are in normal prostate epithelium. We mentioned 2. Here, is it 2 or more than 2? More. Good. And is it spreading into the basement membrane? No. So this is intraepithelial neoplasia. Good. How about here? Is it spreading? Yes. So prostate adenocarcinoma. Easy. Now here we have a very important image, which is the single file line appearance. Okay. So this is prostate adenocarcinoma. Single file line appearance. Okay. They're all in one line. Okay. Or the Indian filling sign for some reason. Now here we have immunohistochemical staining using what? Or what is it staining? What is the marker? PSA. Good. Prostate adenocarcinoma, immunohistochemical staining against PSA. Good. Now here, where is the spread happening? This is what? Nerve. Good. So it's spreading perineural. Here, what type of metastasis do we see here? Osteoblastic metastasis. And in prostate cancer, it usually causes back pain, which is one of the important early features. Okay. Or we say early, but it's late. Okay, because it's metastasized. But usually, I'm not going to go into the detail of it, but the back pain itself, there's characteristic features. If you have back pain at night, you suspect cancer. Okay. In a patient that's 60, the pain doesn't go away and has some risk factors for prostate cancer, you suspect prostate cancer. Yeah. So that's basically prostate adenocarcinoma. Now, the treatment of it is anti-androgen usually. Okay, you block androgens. Simple. So the first class is GnRH agonists. So GnRH will go to the anterior pituitary and cause release of what hormones? LH, FSH. Good. LH and FSH will go to the testes, okay, and will cause testosterone synthesis. Okay, you don't need to know which one activates which cell. That's all you need to know. Okay, but it's Leydig cell that secretes testosterone. Okay, so now what do? Is you give, in this case, an agonist. So what will an agonist do? An agonist, it's GnRH agonist. So it will go and then activate LH and FSH release. So initially, it's going to cause worsening or better symptoms? Worse, because you're going to cause a surge of LH and FSH, which will then cause increased testosterone. Okay? Now, over time, remember in POD is if you activate a receptor too much, what happens? Sensitization or downregulation of the receptor. Okay? Because it's activating too much. So when you have that downregulation, will LH and FSH be secreted more or less? Less. Okay, no. Will testosterone be secreted? Less. So that's why we give it continuously. Okay, so if you give it continuously, leuprolide or a GnRH agonist, this will downregulate the receptors later on and cause a negative feedback. Then you have an antagonist, which is blocks it, and that's it, khas. Okay. Then we have androgen synthesis inhibitors and androgen receptor antagonists as well. Okay, very simple is prostate, BPH, you try to dilate or inhibit dihydrotestosterone. Simple. Prostate cancer, anti-androgen. You just want to inhibit androgens. That's it. That's it for the prostate. Now, very simple. This is just a diagram differentiating BPH and prostate cancer. The one thing I want you to remember is the thing about PSA. It's an high PSA does not directly diagnose a patient with prostate cancer. It's very non-specific and stuff. So you need to further investigate it, okay? But PSA is useful for us in monitoring the patient. But it's likely, if it's very elevated, more than 4, more than 10 even, then it's likely that it might be prostate cancer, okay? However, if it's less than 4, that does not exclude it. That's very important to remember. And that's it for prostate disorders. Do you guys have any questions? Good. Tamam. Now we go into testicular disorders. So the first thing is some benign scrotal disorders, okay? Now, important physical examination things that you want to remember, okay? If I tell you this patient had a painless mass in the testes or in the scrotum, what do you suspect? Tumor. Painless mass in the scrotum, tumor, okay? Enlarged scrotum that transluminates. What do you suspect? Hydrocele. The key term is transillumination. It's the only one. Okay, hydrocele. Good. Dilated veins or bag of worm appearance in a scrotum. Varicocele. What if it's sudden onset? What do you suspect? RCC. Good. Severe testicular pain with high riding testes and tenderness. Torsion. Okay? Good. Severe testicular pain that is relieved when you elevate the testes. Specifically, okay, just think infection. More specifically, the diagnosis is epididymitis, okay, which is more posterior scrotal pain, okay? But anyways, good. These are most of the scrotal disorders. We basically finished. To go over it, hydrocele is defect of a patent, what's it called? patent tunica, what's it called? Processes vaginalis, okay? Patent processes vaginalis, which is a communication between the peritoneum and the tunica vaginalis of the scrotum itself. So if you have patent processes vaginalis, it basically the peritoneal fluid will go into the scrotum and cause this dilation. It transluminates. If it transluminates, think hydrocele. تمام? Ignore spermatocele. You don't really need to know it, but it's usually the thing about it is it's post vasectomies. Okay. Varicocele is dilation of the pampiniform plexus in the scrotum itself. Okay. Usually indicating some sort of obstruction proximal. Testicular torsion is torsion of the spermatocord. Okay. Usually very dangerous, severe onset pain, very severe. And you need to treat this surgically immediately to preserve function. Now, what is the danger between varicocele and testicular torsion? Is it increases temperatures in the testes. So what does increased temperature in the testes cause? Infertility, number one. Number two, atrophied testes. Yes, atrophied testes. What can it cause? Cancer. Okay, good. Just remember infertility mostly. Tamam. This is the benign scrotal disorders. Now, this is a normal testicular ultrasound. This is the testes itself, and this E is epididymitis. If you have increased vascularity in either of these structures, it's indicating infection usually. Tamam. So over here, there is increased vascularity on Doppler plus more hypoechoic structures here in this structure. What is this? Infection. So if this is the testes, what's this right next to the testes? Epididymis. So epididymitis. Good. Now, in this case, you have a patient again with severe scrotal pain, high riding testes. You lift the testes, makes it worse. What is this? Torsion. How can I tell this is torsion? No blood. You do Doppler, no blood going into the testes. So this is testicular torsion. Very simple. This is the blood supply. And is anything going into the testes? No. Okay. Now, you do this image, which is a contrast. You give a contrast to a patient, and usually the contrast will spread into the testes. Okay. Now, in this case, it doesn't spread all the way throughout the testes. What do you suspect? Not cancer. Cancer, the contrast will go into the cancer because it picks up, it's vascular. What is a collection of dead tissue? Necrosis, which is, what if a collection of pus, which is dead tissue? Abscess. Okay. This is testicular abscess. So, in torsion, the entire testes will not pick up contrast. Okay? The entire testes. Why? Is because is blood going to the testes? No. So none of it will go into it from the beginning. This is the entire testicle. In what's it called? In infection, a lot of contrast will go into it. In cancer, it will also pick up the contrast. In abscess, only a portion of it. Why? Is because this is the abscess. Does this make sense? Good. Now, going into the histology a bit of the testes, is that you have two important structures that you need to remember. The seminiferous tubules, which will have all the gonadal cells, plus two important cells, which are the sex cord cells, which are basically the Sertoli cells and the Leydig cells. Sertoli cells are over here, helps with spermatogenesis. Leydig cells are over here, which support it by secreting and synthesizing testosterone. Okay, this is a normal testes. Now, testicular tumors can arise because of these two important cell lines, either germ cell tumors, which are 95% of it, or sex cord stromal tumors, which are very small amount. You don't need to know the sex cord stromal tumors at all, okay? But there's two types, Leydig and Sertoli, from these two cells. Majority of the tumors come from germ cell tumors, okay? Now, germ cell tumors, what is the most common germ cell tumor? Seminoma, good. Okay, seminoma. We differentiate germ cell tumors into two, seminomas and non-seminoma. Okay. So seminomas present as painless mass in a young adult usually. And is it good prognosis or bad prognosis? Good prognosis. That's why we differentiate. Non-seminomas are usually less, the prognosis is poor than seminomas. Good. Now, the risk factors are very important. Number one is cryptorchidism, which is what? Undescended testes. Perfect. Undescended testes is an important, very crucial risk factor. The other one is Klinefelter syndrome. Okay. Now, these do not transluminate. And an important thing that's about these testicular tumors is, do you want to take a biopsy from these tumors? No. Why? It says it here, but seeding of the tumor. When you insert the needle, you might seed the tumor. That's basically that. So now over here, you have a patient who has been working as a construction worker who does a lot of drilling and later on presents with an infertility. What do they have? Atrophic testes. Good. Okay, simple. Or a patient who had cryptorchidism, okay, that wasn't repaired properly or wasn't repaired till late, can develop atrophied testes. Yeah. Now, cryptorchidism, just something about it is we need to treat it before they reach the age of 2. Okay, so usually we treat it under 1 year, 1 year of age. Okay, because at around 2 years, it's the atrophy changes start to occur. There's some fun fact for you. Testicular atrophy. Now over here is that you have, because of cryptorchidism or Klinefelter or whatever, you start to have some changes that occurs at the testes. What change is occurring in this case? IGCN, which stands for intratubular germ cell neoplasia. Now here it describes basically the neoplastic process that occurs at the level of the testes, the germ cells, because of their risk factors that they had. What are the risk factors? The most important risk factor for IGCN is cryptorchidism. Okay. Now how could you tell that this is IGCN? Okay, is you stain it. What stain are we using here? Give me the acronym. PLAP. So PLAP. Good. You stain it by using PLAP. What is the next tumor that's stained by PLAP or positive for PLAP? Seminoles. This is a risk factor for seminoles. Okay, that's it. This is basically the precursor if you want to think about it. That's it. Now over here, you have a tumor. Yeah. Now you have a tumor. I told you already, but you have this mass that uptakes contrast. You can see the white bits that uptakes it and uptakes Doppler. In a young adult with a painless mass that was found incidentally. Seminoma, good. This is a testicular mass. How do you know it's a testicular mass or a tumor? Because number one is it uptakes contrast. Number two is you can color it with Doppler. It uptakes, it's vascular. Okay, so it will be positive on Doppler. This is a seminoma. Now, usually it's this golden mass. Okay, so about the seminoma drilling example, is drilling itself can cause atrophy testes. Do you guys know why? Or any like case of just increased temperature? Okay, the heat. Heat can cause testicular atrophy, which is a risk factor for cancer. Okay, good. So this is a golden tumor, okay, very small golden tumor, okay, that occurs in the testes, seminoma. Now, seminoma, you can clearly tell over here, this is a normal somewhat normal testes. This is where you have the seminoma, dysplastic features. تمام. What cell is this? Syncytial trophoblast, which is a multinucleated cell. What is secreted from syncytial trophoblast? Beta HCG. Good. Is this seen in all cases of seminoma? No. Only some cases of seminoma will have positive beta HCG, not all. Only the ones, which is around 20% of the time, with syncytial trophoblasts. Okay? And this is staining it with beta HCG. تمام. Seminoma, how do you stain it? Is PLAP. Some cases will have syncytial trophoblasts present, so you'll have beta HCG present. تمام. Seminomas, most common testicular cancer, painless mass in a young adult. And it has good prognosis. These are some key words to remember about seminoma. Now, you have this tumor, which is heavily necrotic, and key term is painful testicular mass. Embryonal carcinoma. The most important thing to remember is from all the testicular tumors, embryonal carcinoma is painful. Okay? This is important because usually in cases, this is the one that's painful. And it's necrotic. That's also another thing to remember about it. Now, how about this tumor over here? This is yolk sac tumor. Good. So what histological feature do you see in yolk sac tumors? Schiller-Duval bodies. Good. Now, last thing is what marker is positive in yolk sac tumors? Alpha-fetoprotein. Remember this. Yolk sac tumor, it's painless. Schiller-Duval bodies, which will be given to you in any question. And lastly is alpha-fetoprotein positive. Good. Now, how about over here? You have this very hemorrhagic tumor with abundancy of syncytial trophoblasts and cytotrophoblasts. This is choriocarcinoma. Good. What marker will be positive in choriocarcinoma? Beta HCG. Why? Syncytial trophoblasts. Easy. Now, you have this tumor that presents with multiple tissues. Calcified tissue, teeth, teratoma. Okay. What is this tissue over here? Cartilage. Good. This is teratoma. Do you need to know what is mature, immature teratoma? Not really. Where will you learn this in more detail? You're going to revise all of these tumors when you get to repro for ovarian tumors, just to let you know. Okay? You're going to take the same ones. Choriocarcinoma, embryonal carcinoma, not really yolk sac. Teratoma will be very important then. Yeah? That's that. This is a summary of all of it. Just remember for yolk sac tumor, also the age of the patient is usually less than 3. Yeah? But everything else we mentioned. Are testicular disorders clear? Remember the key terms for differentiating all these tumors, all these scrotal disorders. These are very important. Now we go to the last segment, which is infectious, which will include all of micro plus the patho and radiology features of the infectious diseases. Before I go into that is we need to identify and kind of define what is a UTI. UTI is a urinary tract infection. Now you can classify it based on location. So you have upper urinary tract infection and lower urinary tract infection. If it's upper urinary tract infection, what organ is involved? Kidneys. So if you have infection of the kidneys, what do we call it? Pyelonephritis. Easy. Lower urinary tract infection involves the bladder. If we have a bladder infection, what do we call this? Cystitis. Good. If we have a prostate infection, what do we call this? Prostatitis. Good. Okay. And if it's in the urethra, you call it urethritis. This is by location. Upper urinary tract infection is worse than lower. Just take it as that. Now, then we have by clinical presentation. We have something called asymptomatic bacteriuria. Okay. What I want you to remember about this is what is asymptomatic bacteriuria? Is a patient, number one, is asymptomatic by presentation. They don't have any symptoms. They come to you and they do urinalysis for some reason, and for 2 times in a row, they present with positive bacteria or positive WBCs plus bacteria. This is what we call asymptomatic bacteriuria. This happens in a lot of patient populations, but the ones I want you to remember, it can happen in children, it can happen in non-pregnant females, and it can happen in pregnant females. Out of all three of these, which one is very dangerous is pregnant females. And I need you to remember pregnant females and asymptomatic bacteria. Why is that so? Is this asymptomatic bacteria in pregnant females can predispose them to pyelonephritis, to sepsis. Okay, so that's what's important about it. Okay, now UTI itself will cause the symptoms of UTI. So if a patient has dysuria, lower urinary tract symptoms such as dysuria, dysuria, clouded urine, for example, with no abdominal pain or flank pain, what is this? Just a lower urinary tract infection. That's it. That's what that is. Okay, if it's just dysuria. Okay, or pain over the pelvis or the bladder itself. Cystitis. Okay, if they have flank pain, then this is gonna be most likely what's it called? If they have flank pain, then this is going to be most likely pyelonephritis plus fever and plus whatnot. Okay, so this is upper urinary tract infection, how it presents us. Then we have by severity. Severity, we can diagnose it as either uncomplicated and complicated. Simple. Uncomplicated UTI, which is the one that we see usually in females with simple cystitis. Okay, this is an uncomplicated UTI. If a male presents with a UTI, is it uncomplicated or complicated? Complicated, good. If they have pyelonephritis, is it complicated or uncomplicated? Complicated. If they have, if they're pregnant with a UTI, complicated, okay? Then the last stage of severity is if they have sepsis, okay? Then by source of infection, which is important. Now you have community acquired, which happens in everyone. Then the healthcare acquired. Now the healthcare acquired depends on one important risk factor, which is what? Catheter placement. Because of a catheter, it's a source of infection. What important organism is associated with catheter-associated urinary tract infection? Proteus. What's the most common organism? E. coli. What's the most common overall cause of UTI? E. coli. Good. In a young female, what's the second most common cause? Young sexually active female. Staph saprophyticus. Good. In a pregnant female, what's an important cause that can cause sepsis in the child? Group B strep or strep galloliticus. Okay, good. Perfect. So that is by the source of infection. Now, catheter-associated UTI, treatment of it is by all the antibiotics and all that stuff, plus you just simply remove the catheter. Okay. Now, by frequency is recurrent UTI. Until now, UTI classification, the types, and so far, is it all clear? Perfect. Now we go to the organisms. The most common cause is E. coli. Okay, E. coli is what type of organism? Or the second half of third year, this would be easy. Gram-negative, cocci or bacilli? Bacilli, good. Now, is it indole positive or negative? It's an important factor, something called indole, Indole. Why is somewhat important is it differentiates E. coli from Klebsiella. Okay, in terms of the factors, indole positive is E. coli, indole negative is Klebsiella. Plus, Klebsiella will have the large mucoid capsules and whatnot when you see in the culture, okay, in the agar. Tamam? Why am I telling you this? I wouldn't tell you if it was important. It's because in our exam, that was one of the differentiating points between the two organisms. So, telling you from now. Now, next is Staph saprophyticus, as we mentioned, as the second most common cause. And yes, E. coli is indole positive. And it's in young sexually active females. Ignore serratia. Now, enterococci are important because of the extended spectrum. What's it called? The one that's basically resistant to the antibiotics, which is the cephalosporins. Okay. Which part do you want me to repeat? Indole. Okay. So indole positive, which is a factor, just remember it's a virulence factor that you test for, is positive in E. coli, just E. coli. Remember E. coli. If it's positive, E. coli. If it's negative, or the patient with, they describe to you as gram-negative rod, you might think of Klebsiella pneumonia. Okay? That's the only thing, the only reason why I'm telling you. Just a factor to differentiate these two organisms. Okay? Proteus, as I said, it's a gram-negative rod, and it is urease positive, which is an important virulence factor, and it causes the struvite stone. Pseudomonas is important in healthcare-associated UTIs. Now, when you're doing urinalysis markers, you test for leukocyte esterase and nitrates. Leukocyte esterase signifies what? WBCs. That's it. Pyuria. Good. Positive nitrites, gram negatives. Okay, or E. coli mostly. Perfect. Now that's pretty much all I need to mention over here. I don't think anything else is needed. Now over here, a patient with dysuria, pelvic pain, suprapubic pain, and a female. What is this? Plus this image showing you thickened bladder wall, cystitis, simple. Okay, easy. In this patient here, is they have flank pain, fever. What do they have? Plus, a week ago they had cystitis, pyelonephritis. Good. Now, what finding do you see on these images? Striations. Perfect. Good. Striations. Okay. This is a sign of pyelonephritis on CT. Okay. Striations. Good. Now, for the striations or the pyelonephritis, you can have some complications that occur. There's two complications. Number one is this. What complications occurring here? Or no, yeah. If you don't treat it, it can lead to this complication. What happens? Cortical scarring, which is seen in acute or chronic pyelonephritis. Chronic pyelonephritis. So cortical scarring, for example, you can see clearly here is that the kidney, it's all gone. It's all scarred. Why? Is because of chronic pyelonephritis. So it's irregular borders of the kidneys. Okay, so this is chronic pyelonephritis. What is this complication over here? This is the kidney that's affected. And you can clearly tell there's two stones. One stone over here, one stone over here. So what is happening here? Emphysematous, which means what? A buildup of what? Air. Good. Perfect. If there's air buildup, usually because of gram-negative E. coli, or usually gram-negative organisms, they start to produce air, and this will cause emphysematous pyelonephritis. Okay? How about here? Xanthogranulomatous. Good. Not air, the other one. Okay? Which is fat and other tissues. Now, if you also don't treat acute pyelonephritis or pyelonephritis in general, you can have a collection of dead tissue, which is what this is. What is this? Abscess. So this is an abscess. You can clearly tell there's perinephric fat involvement, which basically means is that it's it's evading into the fat around the kidney. Easy. And then you can clearly tell these spots over here. What are these spots? These black spots. Air. Okay. Why? Is because abscess is a cavity. It will have dead tissue and pus and whatnot, and it will have the air component. Okay. So that's perinephric abscess. Now we go quickly into organisms, and then we go descend down into prostatitis and whatnot. This organism, gram-negative, most common cause of UTI. What is this organism? E. coli. Now, what important virulence factor of E. coli causes UTI? Fimbria, pili, perfect. Good. This is what's causing the UTI. This is what's allowing it to cause UTI. LPS will cause what? If you remember. Sepsis. Good. Down. Good. That's it. This gram-negative organism, the patient had a struvite stone with a swarming motility pattern. Proteus. Good. Now, we go down to prostatitis. Now, prostatitis, we can differentiate it two types. Acute chronic, there's more, but acute chronic is the one I want you to remember. And the time period is it depends on the time period. Less than 3 months, an acute onset is acute prostatitis. More than 3 months, chronic prostatitis. Easy. Now, acute prostatitis, how does it present with? Similar to cystitis, very similar, plus minus back pain, and obviously it's just an adult, okay, and a male, okay. So that is acute prostatitis. The risk factors are anything that causes stagnation of urine, okay, BPH, bladder outlet obstruction, and importantly in younger individuals is STIs. So if I ask you, what is the most common cause of acute prostatitis in patients less than 35, what are the organisms, if you know? Good. Neisseria gonorrhea and chlamydia. Perfect. What if it's an adult patient above 35, like their 50s? The most common, which is the most common cause of all UTIs? E. coli, and you have Pseudomonas. Excellent. Good. Now, chronic prostatitis, if this inflammation of the prostate is occurring for longer than 3 months. Now, when you're diagnosing patients with prostatitis, in acute, you need to obviously collect sample, urine sample, right? In acute prostatitis, what maneuver is contraindicated? Massaging. Good. Massaging the prostate is contraindicated. When you're trying to diagnose a patient with prostatitis, what you do is there's multiple sequences of the prostatic or the urinary collection itself, okay? To think about it, it's acute prostatitis happening in the prostate. So you want to massage the prostate to release all those, inflammatory cells, bacteria, and whatnot. And obviously, when you collect it afterwards, it's going to be more WBCs and whatnot than the first sample that you took. In acute prostatitis, it's contraindicated. When you do digital rectal examination, you feel a tender prostate, just touching it is tender, you don't do a massage. Khas. You know that this is acute bacterial prostatitis. In chronic prostatitis, you can. Okay, it's really not that many. It's not contraindicated. And that's basically okay. So when you're diagnosing, actually, I'll say it here. So in prostatitis, you have the 4-glass test. Okay. Now, the first portion of urine that you can collect, where is it coming from? When the patient first starts urinating, where is the urine from? Urethra. Does this hold any value if you're trying to diagnose cystitis or prostatitis? No. Okay, because it's the first portion. Then you have midstream. Midstream, where is the urine coming from? Bladder. So if you're trying to diagnose cystitis, what do you tell the patient where to collect the urine from? Midstream. Okay, you want to collect it midstream. Then you want to initiate prostatic secretion. You want to release prostatic secretions. Okay. How do you release prostatic secretions? Massaging the prostate. If you massage the prostate, it will induce prostatic secretions. So you collect that prostate secretion, okay? And then you see if it has more inflammatory cells, more WBCs, more bacteria than these two samples. Because it makes sense. That means that you're telling the sample is telling you that the inflammation is coming from the prostate and not anything else. Okay. If you could not collect it from the prostate secretions, what you do is you take the first urination after massaging the prostate. تمام? You cannot do this for what? Acute prostatitis. You cannot do this. You cannot stimulate prostatic secretions. You cannot massage the prostate. So how do you diagnose it? Simple. The patient presentation. Okay. And number two is if you do a DRE, digital rectal examination, you just simply touch the prostate, tender. Done. You do not massage it. This is in theory. We do not do this at all. We don't do any of this because it doesn't help us. If a patient's presenting with pain when urination, low back pain for more than 3 months, chronic prostatitis خلاص. Okay, you do your analysis and whatnot, but doing all this is, we don't really do it. I wouldn't say exclusive for chronic, however, it will help you in chronic, obviously. Okay, because midstream urine is classic. You need it for bladder cystitis. Okay. But if you compare this to this and chronic prostatitis, yeah, it is exclusive. Okay. Perfect. Now we have this. A patient commonly described to you from the Middle East and more specifically from Egypt is presenting to you with painless hematuria. Schistosoma. Good. Schistosoma hematobium. In this case, how do you know from this image that it's hematobium? From this picture, terminal spine, small terminal spine. Good. Now, what's very important for you to remember is what is the intermediate host for schistosoma? Freshwater snails. Good. What is the infective state? Urticaria. Good. And what actually causes the bladder inflammation and the worst symptoms in schistosoma? DAGs. Good. Perfect. This is schistosoma hematobium. There's other ones such as Mansonian japonicum, and these are mostly GI related. Okay, causes portal hypertension, liver stuff. Okay, so you don't need to know it now. But hematobium, what cancer can it develop into? Squamous cell carcinoma. Perfect. Last thing is on imaging. What can you see? Calcification in the bladder wall. So what is this? Cystitis, more specifically caused by what? Schistosoma. Okay, you see this calcification in the walls of the bladder? Think schistosomiasis. And with that, I am done with renal. Do you guys have any questions? And yeah, sure, I can answer. Sure. And inshallah, this is my last crash course for you guys, for this batch. All my future sessions, which is GI and EndoRepro, are from the recordings from previous year, inshallah. So with that, I am done with your batch, and the 3rd-year crash course series is over. So if you guys need any help in the future blocks, GI and the repro, you have my contact information. Feel free to reach out whenever, inshallah. Allah yafikum. And thank you guys for the ones that were always joining the chat. And you guys are good company, mashallah. Bye, you guys. That's it. Thank you guys so much. And inshallah, easy exam.